Hi, I'm Dr. Bill Adams, and you're here at everybody's favorite program, No Spin Live, episode number 9, where you get to hear your favorite and most skilled plastic surgeons tell you about hot topics in plastic surgery. So with us today, we have, starting from the top, Dr. Sean Doherty from Boston, Massachusetts, Jason Pozner from Boca Raton, Florida, Kevin Smith from Charlotte, North Carolina, and Dan Vecchio from Boston. So listen, guys, Super Bowl just ended. Incredible. We won't get into the football part, but there was some interesting crossover to plastic surgery. What do you guys think about this thing? Tom Brady has Botox. His forehead looks pretty smooth. What do you think, Jason?
I think it looks great. You know, maybe that helmet pushing against his head for so long has smoothed it out. But if he got Botox, more power to him. Looks good.
Sean, what do you think?
Yeah, I agree. I think he looks great, obviously, from Boston. No problems with him at all. I saw him at the parade today. He had a hat on, so I could not verify the Botox.
We need another Bostonian. Del Vecchio, you're from Boston. Do you know if he had Botox? What do you think?
Hey, if you were married to Gisele Bundchen, you'd be in a freaking hyperbaric chamber every day trying to look good. I have no problem with Brady doing whatever he needs to do. I'm sure he's had hair transplantation. The guy looks great. He's 39 years old. He's good for 2 more seasons. And if he's had Botox, so what?
Yeah, nothing wrong with Botox. You know, you could tell in the first half of that game that he wasn't scowling, and you know he felt it. So Botox helped.
All right, what about the other big trend? Lady Gaga, she was doing this show. Some people liked it, some people didn't, but it seems to me her belly is getting a lot of social media. So what do you guys think?
Lady Gaga's a great artist. It was a great show. People need to get over themselves. It's great that she's proud enough to stand up there, do her thing, and if it's not a problem for her, it should be a problem for us.
Well, but Jason, was the pooch a problem?
But you know what? She's a shape. Her singing was awesome. I think it was a little more of a wardrobe malfunction. They should have had a little higher kind of thing on for her because that was definitely pooching out a little bit. So wouldn't have been my first choice in wardrobe.
All right, well, listen, boys, let's move on to the topic. So first topic is this thing. Johnson & Johnson was just sued over leaky breast implants. Jason, lead us off.
Come on. Is this 1992 all over again? You know, we went back to the drawing boards. We did tons of studies on this. Implants are safe. They're going to break. They don't cause any long-term medical problems. We've already been through this route. People looking for more money by trying to sue more people.
Kevin, what do you think?
You know, this is another thing of causality. You know, this woman did have problems. There's no doubt about that. But blaming it on an implant that we know is generally very safe is not the right way to go. And people are making this sensational.
Sean, you agree?
Yeah, I do. I mean, it's certainly the last thing that any of our patients or our industry needs, some hysterical sensationalism of something that goes on with implants that we know how to take care of them. We talk to our patients about it, and it really should be the standard of care the way this patient gets cared for.
Dr. Del Vecchio, you think is this a frivolous lawsuit?
Of course. I mean, it's like hemlines, the stock market, and boob jobs. They just cycle. You know, 30 years ago, 20 years ago. This is just, you know, a patient and an attorney who's using litigation as a way to, you know, get publicity. To J&J, multi-billion-dollar company, they're in probably like 500 lawsuits at any given time. This is a drop in the bucket. This is more driven by the plaintiff than anyone else.
And Dan, so if the implant ruptures, which it certainly can do, is that gel? Does that gel cause health problems? Has that been studied before?
Well, to my knowledge, there's really no evidence that leaking gel, especially the cohesive gel, causes any problems besides what we know causes problems, which is just local inflammation. But we're trying to link this to, you know, all sorts of, you know, osteoarthritis and autoimmune diseases. That never panned out. So, you know, I just don't see this going anywhere. You're right, the implants are going to malfunction. But silicone is in baby diapers, it's in your hair gel, it's in a lot of your tablets, so silicone's in everybody.
Yeah, exactly. 34 studies, never been anything that's been proven to cause any kind of health problem whatsoever. It's been the most studied medical entity in the history of medicine. So, all right. Second topic is interesting. It's about actually Las Vegas becoming a destination for plastic surgery tourism. And this was picked because we've talked about medical tourism before, but what do you think about this idea of, it's a little different. Medical tourism is people going outside the country to cut rate plastic surgery versus this is somebody going to a U.S. city. Is that different, or what do you guys think about that? Dan, why don't you lead it off?
Well, I mean, people like to go to Las Vegas because they like to gamble, right? So if you want to gamble and have plastic surgery in Las Vegas, it's pretty consistent.
Kevin, what do you think about this?
There's good plastic surgeons in Las Vegas. There's good plastic surgeons in your city. There's no reason to go cross country. And the most important thing is that when one has plastic surgery, you need to be around your surgeon with access. It takes months to heal. It takes 6 months before things have really settled down. And if anything happens and you're halfway across the country, who do you go to? You can't jump on a plane and go back to Vegas.
Sean, what's your thoughts?
Well, I think that there are some procedures that certainly some doctors in this country do better than others, so I can understand traveling for a specific doctor for specific procedures, but in terms of breast augmentation, I think that we all do a pretty good job of it, and you can certainly get a good procedure, safe procedure in your hometown, so I'm not quite sure it's necessary to risk any type of post-op issues by traveling to Vegas.
If they're going to the surgeon they really want, and it's a quality place and quality person, then that's probably fine. But if they're just picking it because they want to go stay in a hotel and sit by the swimming pool, that seems a little bit ridiculous.
I think there's two questions with this. I think we all are experts in certain things. We do all get fly-ins from different areas of the country. I do these, crazy breast revisions that may come from a certain area down to me, but they're coming to me for a certain level of expertise. I don't think people are coming to Florida because they want to get a boob job and sit in the sun, because they're probably holed up in their house afterwards taking Percocets. So I think that you all are right about that. You need to have local docs for local procedures, but we all know that we all get fly-ins for specific things that we might have a certain level of expertise at.
All right, so we've got some quick hit plastic surgery hot topics. We picked these just because they're kind of hot, things up for debate. So the first thing is the periareolar incision for breast augmentation. It's been shown to have 8 to 10 times higher capsular contracture rate. Some people still like it, some people have abandoned it. So Jason, where are you in this?
You know what? In the 90s, I did a lot of Transacts. In the 2000s, I did a lot of areolar augs. Since 2010, I'm pretty much completely inframammary incisions, except if the patient's really dark or has a tubular deformity or some issue, in which case I'll do an areolar incision. But I try to go inframammary whenever I can. I think it's lower capsule rate, easier surgery, cleaner, very little bleeding. So that's my preferred method for most patients, not all.
What do you think, Sean?
Yeah, I very much agree with you, except for the tuberous breast. I think the inframammary fold is my preferred avenue of doing the procedure. And the patients are so much more aware these days, and I think they're reading what we're reading and things that we say online. So they're on board for the most part.
Kevin, what do you think?
I think that patients like the periareolar incision because it's so inconspicuous. And when done well, I think the real issue here is that when you pass an implant through the breast tissue, as opposed to completely avoiding the breast tissue with an IMF, that is likely the reason for a higher incidence of capsular contracture or infection. And I think that you certainly, with your Atom solution, have shown that better antibiotic prophylaxis, a cleaner wound, does decrease capsular contracture rate. We're still unable to get that rate to 0. And if we can be in the low single digits of capsular contracture rate, whether we use an IMF or a periareolar, I think whatever works for us and whatever our patient wants is legitimate.
Del Vecchio, are you thumbs up or thumbs down on the periareolar?
Thumbs down.
The scar
Enough
that we
said.
talk about with the periareolar incision goes all the way to the pectoralis muscle. It's not just a skin scar, and that scar can really pucker. And when you really see this when you see someone who's had 3 or 4 breast operations all done through the same periareolar incision, you just start to destroy breast tissue. I only use it when the patient needs some type of areolar reduction, and then I'll typically put the implant in through that incision. But I think for all the reasons that have been said, I don't like it.
All right, next one, implant shape. You're gonna keep going, Dan. Does implant shape matter? We've got round implants, we've got anatomically shaped breast implants. A lot of new things in the US have been approved. There's a lot of things that are said, but does it matter?
It doesn't matter, and this is a cram down from the medical device companies to tell us that these devices are better, they get better results, but in actuality, you can get a very good result with a smooth round gel implant. If you sit a smooth round gel implant up, it sags down and creates a teardrop shape. There are some indications for textured devices, anatomic devices, but they're really small. The current penetration is 10%, and the current penetration when it first came out was about 10% in recon. So we haven't seen an adoption over 3 years.
Kevin, what do you think on that?
I think the shaped implants are important as a reconstructive implant. I think if you have to have an implant that has to create a shape on a breast, I think the shaped implants are very good. For instance, a tuberous breast deformity where you've got to stretch out the inferior pole, I think the shaped implants are good. I rarely use them. I'm a big fan of smooth round. The breast is really an amorphous blob of tissue that when it stands up, it teardrops, when you lay down, it pancakes, and that's the way a smooth round implant acts.
Sean, where are you on this?
I agree. Smooth, round, all the way. I think that for both what Dan and Kevin said is that the smooth round become a shaped implant when they need to be, when the patients are standing up. The pectoralis muscle makes it a shaped implant. And it's safer. I just think we worry about less, and it provides excellent outcomes. So I definitely let my patients know I prefer round implants.
Dr. Pozner, does shape matter?
I'd love to argue with everybody, but I'm going to agree with everybody here. Plus, I live in Florida. Everyone wants to be in a bathing suit. I really think the upper pole in a smooth round gel implant gives you a better upper pole. So I'm a smooth round under the muscle guy.
Okay, under the muscle. Stay with that, Jason, because the next one is, does pocket plane matter? So subpectoral or subglandular, does it matter?
I'm not a subglandular fan. I did a bunch in my early days in practice. I thought there were a lot of mess-ups from that. I do not like the long-term results of subglandular implants. So for me to do subglandular, you got to really twist my arm really hard. I'm a submuscular guy. I do a lot of revisions. I put everyone under the muscle, and I'm super happy that way. So I'm a submuscular, thumbs up.
Sean, where are you?
Yeah, I agree. It's I always have to think, why am I not putting this underneath the muscle? Because I want as much tissue on top of the implant to smooth a more natural outcome. I think there are some cases with some ptosis, maybe even a tuberous patient might need it subglandularly, but for the most part it's for the muscle.
Kevin, there was a time when everybody did it subglandular, but certainly the tide has turned a little bit. What do you think?
I still do a lot of subglandular augments. As long as they've got enough breast tissue, you've got good coverage over the superior pole. And patients like not having animation, that's a possibility with submuscular implants. They like to have a little nicer cleavage. Sometimes you see a beautiful augmentation who has cleavage that you can drive a truck through because the implant can't move more medially than where the muscle inserts into the sternum. So with good patient education, telling them the pros and cons of each, you can help the patient decide and advise them accordingly whether to go on top of or below. I think we have implants now that behave nicely in a subglandular position, very different than we had 20 years ago.
Dan, subglandular or subpectoral?
I've never put a subglandular breast implant in. I think this is less about the implant and more about the soft tissue. If the patient has inadequate soft tissue, I'll still put a submuscular implant in, put fat over it. If I need cleavage, I do that with fat. I never do cleavage with an implant. So the argument to do subglandulars so they get the implants closer doesn't exist in my practice.
I think those are some great points. We're going to move on to the last topic. This is a story that just came out from a local Washington, D.C. affiliate about a woman got textured breast implant after cancer, but she was never warned about the major side effect was that it could cause a lymphoma. So, Dan, I'm going to have you start out. I mean, what do you think about this story, and are there some misnomers in the story itself?
You know, I just, over and over, we have evidence of the media misrepresenting the science. And let's talk about a couple of quick facts for everyone. First of all, there's no causal link between textured devices and ALCL. Okay, there may be in the future if the numbers get strong enough, but as of today, there is no direct causal relationship between the two. Number one. Number two, for news to misrepresent that is really like unethical. And it gets people nervous, it creates hysteria among patients. So I think this is not only a bad story, it's a disservice to patients.
Kevin, what do you think about this story?
Well, this is another example where it's being sensationalized. People are back on that bandwagon of worrying about implants when safety has been shown to be quite high. But the numbers are very, very low. 300,000 augments in the United States alone, and there are, 28 proven cases so far in the United States?
So Sean, what do you think about this thing about warning patients? Because one of the things is that there's actually never been a smooth implant case of this entity. And I agree with you, Kevin, it clearly is not a lymphoma, it's a lymphoproliferative disorder, and there's actually good data to support that, which wasn't brought out in this story. But if you're using a smooth implant and there's never been a case in the history of the world, is it something you tell your patients about, or how do you handle that?
So I think we do need to talk to our patients about it, because who knows if our patients are going to see this story, which, FYI, if you look at it, it's filled with typos. So I just question kind of the origin of this actual story. But I just think it's one more thing that we need to talk to our patients about and let them know that we know about it, we're thinking about it. And I just think that the take-home message is you have a relationship with your surgeon that's going to be forever. And so you just, it's important for follow-up and just monitoring and taking care of things as they come up.
Jason, what's your thoughts on this?
I think I'm going to agree with all the rest of our esteemed KOLs on this call. I think that it's something that still needs to be studied. I think it's very early in our understanding of this, and I'm a smooth round fan, so it's one less thing for me to worry about.
So that's going to wrap it up today for episode 9 of No Spin Live. We want to thank our panelists. That was some great information, guys. Appreciate your time. And if you want to see more of this, join us on theplasticsurgerychannel.com.